Welcome back from the break. I hope you're well caffeinated. So now we're going to dive more into discussing the results and the future of the products of this project. So yesterday we heard about the results, and in the next two panels we'll first discuss and debate the results in the context of both the qualitative and the quantitative perspectives. And following that, we'll discuss the future ideas for the Itfits-Toolkit in both research and in practice. And for both panels, feel free to just ask any questions you'd like for the panel members in the Q&A function, and we'll see if we can filter them through to the panelists. On the first panel, I'm pleased to welcome back Tracy Finch and Josien Schuurmans, and also introduce Josien Schuurmans. So just briefly, Tracy Finch is a professor of healthcare and implementation science in the Department of Nursing, Midwifery and Health at Northumbria University, Newcastle upon Tyne in the UK. And Tracy led the qualitative study of the usage of the Itfits-Toolkit. And Josien Schuurmans is a research associate at the Department of Clinical Neuro and Developmental Psychology at the Vrije University in Amsterdam. Josien initiated and designed his ImpleMentAll project and coordinates the scientific research in the project. Dr. Josien Schuurmans is a senior researcher and practicing psychologist at the Department of Research and Innovation within the GGZ in Geest, I think it's pronounced, which is her clinical position in the hospital in close collaboration with the University in Amsterdam. So her PhD focused on the treatment and epidemiological study of late life anxiety disorders. Over the years, she served both as a chair as well as an active member of several national task and workforces for the establishment of new treatment guidelines in the field of mental health. And in recent years, her research focus has shifted to the feasibility, implementation, and effectiveness of blended care of mental disorders in secondary care settings. She's one of the co-founders of the Mindway clinics, and as a central ImpleMentAll trial manager, she has assumed a coordinating and consulting role to support both the overall project and the sites in the standardized collection and storage and management of the data, as well as the translation of the generic protocol into the local site-specific protocols. So I would like to welcome Tracy, Josien, and Josien to this panel. And for everyone in attendance, please submit your questions using the Q&A function at the bottom of the screen. But before we start, I'll just quickly recap the headline results of the project's results. Those you saw yesterday, but just this one is very brief. All right, so this is our new web page, our new landing page for the toolkit. That's how it'll look in the future, if any of you should be using it or wanting to read more about it. But let's jump to the next slide and look at the overall trial design. So we have two different studies in the ImpleMentAll project. One effectiveness study, which asks the questions if the Itfits-Toolkit leads to better implementation outcomes than implementation as usual. And for this specifically, we measure normalization according to the normalization process theory that you've heard Carl talk about. And secondly, there's a qualitative study, a process evaluation, which aims to understand the mechanisms that shape implementation of the Itfits-Toolkit within and between settings, or really the usage patterns or usage of the Itfits-Toolkit. So what this means is that we have included both a quantitative and a qualitative study in the project, and we've gone to great lengths, we think, to have these two inform one another. All right, for the next slide, you can see very quickly an overview of the results from the quantitative study. So the main question, does the Itfits-Toolkit help? Do we implement better in that group than in the implementation as usual? And that's a resounding yes, but with small effect sizes. So what we fortunately can see is that we can actually quantitatively, even in this project, detect a positive trend, but it's not a very large effect size at this stage. But we're actually pretty thrilled about that, because we, in this project, have included both the development, the conceptual development, and the actual digital tool to use in the toolkit, and then tested it structured over a 4-year period. So I think that's pretty promising. There are some limitations, of course, and we should look at the time and the context dependencies here to understand the results, but I won't dive more into that now. For those of you who haven't seen the session yesterday on the results, you can go back and watch it on video at a later stage. So this is just a brief recap. And similarly, if we look at the next slide, we'll see a very brief overview of the results from the qualitative study, the process evaluation of the usage of the Itfits-Toolkit. One of the things that we particularly noticed was that many responded that it made sense and they saw value in the use of the Itfits-Toolkit. And another thing that stands out is that we saw responses indicating that, or very directly stating, actually, in some cases, that that even though it at some time points were a bit annoying, then the toolkit actually had people stop in their process, take it a bit slower, and be extremely structured around what implementation efforts they were doing, how to investigate the barriers and pair them with strategies, and how to implement that and evaluate that in a very systematized way that they saw great value in, and they could tell that this was something that actually changed their perception of their practices in during their implementation efforts. And these are some things that some have stated they will definitely continue using, even if they don't use the Itfits-Toolkit. This will be in the back of their mind, and it'll impact their way of thinking about implementation. So that's also, I think, very interesting and promising results. All right, this was not fair to the project researchers and a very detailed and long process of analyzing these results, but just a very, very brief overview of the results. Anyhow, now I'd like to welcome to the panel here Tracy, Josien, and Christian to discuss these results. And just to start you off, maybe I would like to ask you to reflect on maybe what was the most surprising results you found?
Oh. Shall I go first?
Yeah, please go ahead.
Okay. Yeah, I think the most surprising thing to me is basically that we managed to pull this off. So this was a really ambitious project, and at the start I'd never think we'd manage getting so many staff respondents included and have them fill in the same measure over time for 30 months. So I think, and develop a tool and test it in both a quantitative and qualitative setting. So I think that's really surprising to me. I also feel the need to sort of defend the quantitative trial a little bit after the last panel discussion, because I do think that we found something really interesting. So I completely agree. It's not a magic wand or a machine. It's a process facilitator. But I also feel that it's interesting that we found a modest effect, especially since there are so many other factors impeding and having a major influence on implementation, for example, in organizational structures that is difficult to change by an implementation team. But I also think it's really surprising that the NOMAD doesn't change that much over time. So we even see a slight negative trend. And you have to bear in mind, these are all people who are completely committed to making this work, because we have a problem to solve. Access to mental health care services is an issue worldwide. And we did this project in order to change things. And I think the fact that even though in implementation as usual, you don't see anything happening, or you see a slight decline, and where it's very, very tough to find at least some positive result, even despite all of our best efforts, is surprising, and we shouldn't sort of glimpse past it because it's uncomfortable.
Yes, certainly.
Should I answer?
Yeah.
Great. Okay. What was most surprising? I would start by saying how well all of the implementation teams in the project engaged with this toolkit, and thinking about the context of the trial itself and the fact that, firstly, we developed this toolkit from scratch. There's no recipe book for that. We were guided by the literature, guided by the evidence, and did a lot of team-based collaborative activities, workshops in order to develop it. So we had no idea how this was really going to work. So that's the first thing. And then really just the fact that what we hoped would happen in terms of how we designed the toolkit, the steps that people would go through, they really engaged with all of those steps, and actually reported back to us some of the things we were hoping would happen. Yes, we engaged with stakeholders, we engaged with different stakeholders, we used strategies we might not have thought about. We found it useful to write plans for our implementation projects. So I think those things were all surprising in the context of what we were trying to achieve. In a good way.
Yeah, Christian?
Yeah, it's surprising. I was actually really surprised that we got this project funded, but that's something else probably. But and we're here, not without scratches, definitely not. It's been quite an effort, but yeah, we run a very good project, and I think it's only to the extraordinary effort that people have been put into this project, including, for instance, also from the central trial management. We have a complete clean data set. All those nomads that we have, they are complete. There are no missing values. And that's only due to the fact how we set it up and how we have had a completely from scratch built data collection system, which never failed. It worked, and that's really cool. So yeah, those things are surprising. But if you look at the results, I agree with Josien. I'm quite surprised that we see on the one hand a very stable normalization, and that's pretty much, or probably very much due to my own lack of understanding, so to say, of how normalization processes work. But something to dive into is we had a quite longitudinal data set in that sense. And I would have expected to see a little bit more of change, so to say, over the time period. Even COVID or even the earthquakes that took place are not very visible, I think, in the data set in that sense, or not in this particular part of it. And so that's for me, that's a question that I would like to dive into more in that sense. Yeah.
So also from all of you, how do you think the quantitative and qualitative studies enlightened one another?
So if I may answer that. So one of the things that we've done, so the process evaluation was continuously ongoing, and the learnings from that we've discussed at various moments during the trial period. And obviously we could only open the data from the effectiveness study after the trial period has been finished, which was in December last year. And then we started discussing with each other a little prior to that also the analysis plan for the effectiveness study, in which we actively discussed with the process evaluation team how to select, for instance, moderators, or what are interesting aspects. Could we, for instance, take a look at the quality of usage of the toolkit, or should we more look into the roles that people have in ICBT service delivery? in understanding the quantitative findings. And we're not finished doing those discussions. And one of these, in my mind, endeavors that I would like to start thinking is also the theoretical implications of both the process evaluation, understanding of the toolkit used, and tailoring in that sense, but also for more normalization perspectives, and try to combine that. And I'm not sure how to, the project ends, but we will need to find ways to keep on going with that discussion.
Yeah, Tracy, maybe you could reflect on this as well?
Mm-hmm. Yeah, so firstly, what I would say is, having been involved in a lot of process evaluations of trials, we often don't get that opportunity to really integrate the trial and the process evaluation studies. So already, I think, even though time is up against us in terms of the project ending, we have been doing that all along in some respect as a team. And I think our understandings of the results, although not quite that yet, are already being informed by that. So I would say there's lots of really good integration already, and we will continue those discussions afterwards. What's been interesting as we've reflected in the last few weeks on the results is the extent to which findings, and there's headline findings, and there's lots of other things that we're sort of thinking about and talking through. What I really like is we've got this huge qualitative data set, and although I didn't say so much about it yesterday in the talk, we have also got a lot of data on the digital platform in terms of what people practically did, and so we've got lots of opportunities to explore different questions, like what were the specific strategies that they actually implemented. What kinds of barriers got in the way to the implementation of their strategies? There are things that we can go to that data and look at. It will be in a great sense quite maybe descriptive, illustrative, and perhaps some limits on how you might generalize, when you've got a smaller number of projects that you're looking at. But I think really informative in terms of understanding. And so it's already given us some questions to follow up after this conference, literally tomorrow and onwards. Yeah.
Josien, I wonder if there's literally at this stage some of the quantitative results that you think about in a different way because of what you've seen from the qualitative study. Mm-hmm. Or is that too early to answer?
No, I think we've already started having discussions about that, and so all kinds of discussions. So, questions like if normalization using the NOMAD is our outcome measure, to what extent did their actual activities align with that? We built this to enable tailoring and adaptation, and although the overall goal was to improve uptake and embedding of their ICBT services, there was flexibility within that toolkit for them to choose projects that might have been more about increasing the numbers of patients that completed their therapy programs, for example, or getting more people in the door in the first place that didn't perhaps always translate into service users in a way that might affect the outcome measure differently. So I think that there's quite a lot for us to explore there. And so that from a theoretical perspective, and great to have that discussion this morning, it makes us reflect on, well, what does this concept of normalization mean? And we're starting to have some discussions about that, and to put, say, the graphs from the effectiveness study together with the things that the sites and the teams within the sites are telling us in terms of what they actually did. So there's so much more scope for us to explore that.
I have a question from the audience, from Nele, who asked, who was leading the implementation process at the different sites? Researchers, psychologists, managers, and who would you would you expect the background of this individual to influence the use of the toolkit or the implementation results?
Not sure who's best to answer that one. I would say.
No, go ahead, Tracy. I think
You want to,
can
Kristen?
No.
I would say it was very mixed. So our implementation leads and teams did come from different perspectives and backgrounds. Some, and partly because they are part of the ImpleMentAll project, were coming more from a researcher background, but others, from different kinds of perspectives, working in organizations. The teams included therapists and others. So I think rather than just thinking always about the lead implementer, what I would say is the teams were quite diverse, and some were bigger than others, so variable. And it was intended to be based around who was best placed within that organization to be part of that team.
And also a part of the question was if the background, if I suppose the way I heard the question was, so if it's a psychologist instead of some other a person with another background education, was implementation lead, would that affect the processes or how they actually use the toolkit or anything like that? Is that something you've noticed?
Yeah. What I would say is teams really reflected on that themselves in the interviews, and they would say things like, well, I'm used to, implementing service changes, and that's my background. I've got a lot of project management experience, and we've said on more than one occasion, at least in our own team discussions, that in some ways this toolkit is a project management tool. So there are lots of different kinds of expertise that, if that's what we're talking about, experience and expertise that are relevant to this, and some who are very experienced at implementing other kinds of initiatives within their services, quite interestingly reflected on how this still gave them a bit of a different perspective, and some different ideas that they could draw on in that work. And they did also reflect on how the toolkit should perhaps have different versions. And this is something we've discussed as a team. What we've done at this time is made it a bit more flexible so that those that are using it to develop an implementation project can move back and forth a bit more easily. We'd kept the structure in to keep it much more guided. So we did have people reflecting on the fact that this was quite structured and there wasn't as much flexibility as they'd like in the real world, or as people that are used to implementing changes in an organization. So I think there was a recognition that some people that weren't familiar with implementation sites, for example, would find it extremely useful, at least for the first time or the second or whatever. But so I think recognition that people bring different kinds of experience to this. They certainly don't need, I would say, to be implementation scientists. And actually, if they were from a more clinical perspective, they kind of bring a different kind of understanding to the nature of the clinical work, that what potential projects might actually affect. So all of those perspectives are relevant and important, I think I would say.
Yeah, absolutely. Maybe just a side note on that is also that some of these reflections that we got back from this study was also used to adapt the toolkit a little bit. So the toolkit that we will bring to the table for future projects or future collaborations is actually more flexible. So this is one of the things that we took in from this. All right, I have another question from Du Young. She asks, one of the issues that were mentioned in the breakout rooms yesterday was that having the set structure, a set of given strategies, can sometimes slow the implementation process, as you have to follow each step. Can the integration of qualitative and quantitative evaluation maybe help overcome this issue? And how? I believe we've touched upon it a little bit, but maybe you can reflect on this a little bit.
Yeah.
I want to, Christian, is this maybe something you could take up for a bit of reflection?
So yeah, I think a part of that is we needed to structure the toolkit in the sense of being able to have an idea of exposure for the effectiveness study. So to be able to measure an effect, you need to be able safely say that the person who used it was actually using it. So that's one of the reasons why we made subsequent steps in the toolkit that people needed to finish before they could go forward. And this is one of the things that we moved into a more flexible way, because we think it's better to indeed accommodate learning effects in that respect. On the other hand, what we actually really felt, I think, and Tracy, you can comment on that much more than I can, but is that even though people needed to slow down because of those steps and some sub-steps in there, it raised the attention to start thinking about certain aspects which they would normally not do that, the implementers in that sense. So that's another aspect of flexibility and steps into building into the toolkit in that sense, I think. But I don't know what you think about it, Tracy.
Yeah. So, for example, we have 4 modules, and our platform, as it was for the project, required them to complete information as they go along, document the decisions that they made. What were the goals? What might have changed as a result of engaging with stakeholders, etc. So, and the thing to bear in mind is that the teams had not seen the toolkit before they crossed over into the active phase of the trial. So it wasn't like they could do that preparation work before logging in for the first time, setting up their meetings as a team. So for the project, it did require people to deal with, spend the first meeting or meetings identifying the issues, prioritizing determinants. In real life, it could be possible to do some of that at once. And the first 2 steps, we did get comments from a number of teams that said they could potentially be done together, the identification of determinants and the matching of strategies. And what we did see in our piloting was some of those same reflections coming out, in that you can decide what the determinants are, but then when you start talking about strategies, you might want to go back and slightly reframe your thinking from the earlier module. So I think that was one of the issues that came up. And that's particularly a point where you might kind of combine the 2 module elements together, I suppose. So there were some things like that were useful to come out that we found through the study. And some of that flexibility we're building in might help, we think, with that.
Pragmatically, what are the lessons learned from conducting this project? Maybe, Josien, do you have a reflection on that from the quantitative trial perspective?
I'm not sure if this fits it, but I think it would be a pity if we didn't have a discussion on this panel about what it means, what we found in the effectiveness trials. I'm just raising it again, sorry.
That's good, yeah, please do.
I think because you're asking how the qualitative and the quantitative trial fed into each other, and I think it's been really interesting to have talks with the Work Package 2 team or the qualitative team about this, and especially also yesterday Carl's speech gave me a lot of ideas about what actually might be happening. And the panel discussion we just had right now. So what I'm wondering about is if there's lots of barriers on the meso and macro level, as Carl put it, right? Which I think we came across quite a lot, because we've talked to the sites obviously a lot, and I know about my colleagues at INGIS and what they sometimes struggle with in their implementation work. There's also lots of factors that they can't really control. So rather than the role of the implementer, I think maybe organizational and even legislative issues might have such a hindering effect sometimes that we put the implementers in the driver's seat, but are they actually able to drive it when there's so many other forces actually making it very difficult to do so? So if there's a roadblock up ahead, how do you navigate past it, right? So that's what I've been thinking a lot about. So is this the fact that we found that it has a modest effect? I think is really positive, and I'm very optimistic about the toolkit in that sense. But I also feel sometimes we're stressing the role of the implementing team, whereas there needs to be certain factors in place in order for this to be successful, for them to be able to be successful. And I'm really interested in hearing also Tracy's views on that and Christian's. So how do we understand it if we do try to integrate it?
Can I start? Firstly, resources. What was clear from our results was that implementation work it's complex, it's time consuming, it needs dedicated time and resource and leadership, and the structure of both the project and the toolkit provided some of those things. So you need that for starters, and then we also found, yes, lots of factors get in the way. Well thought out plans need to be changed along the way. They come up against obstacles, and also to be brief, another issue is timelines, and how quickly you can expect outcomes from some of the activities that the sites were doing, and they were working on those as hard as they could and as fast as they could, but change takes time. So I would just add that in, and I'm sure Christian will have some reflections.
Yeah, I agree with you, Tracy, in that sense, and also the point you're raising, Josien, is very, very important. And I think actually, so my reflection would be from the project perspective and more of what we were able to do. And I think thinking back, we didn't acknowledge those limitations perhaps to the implementation team too much. On the other hand, it was on purpose that we allowed flexibility to the implementation sites to scramble and select the people for their teams themselves. So there is, again, I think the balance between flexibility and let's say expert-driven or a more fixed approach to that. But from this project perspective, we really chose to be as much flexible to that as possible and open to the site's needs and to the site's perspectives to this. And I think for a next project in that sense, and that might be something to think about. Should we not be more, how do you say, conscious and knowledgeable about these differences that drive the implementation processes, at least for mental health perspective or e-mental health realms, so to say. This might be something that the implementation as usual study by Anna can contribute to in more depth, I think. But yeah, that's one of my reflections. We kept it as open and flexible as possible, but it puts limitations to what we actually can conclude from indeed the causal relations between the implementation team and normalization that we've seen in practice. Yeah.
Let's take a last question from the audience. So I think this would probably many be interested in hearing your opinion on. So please chime in, all of you. In which implementation situations would you recommend to use the Itfits-Toolkit, or would you always suggest using it?
If I may, I need to. So if I may go first. Of course. So we set forth with trying to develop a generic toolkit, and I still believe the processes behind the working principles, so to say, within the toolkit that we've put in, and we're actually are not very explicit about those. That would be really a next project to start diving into those more explicit mechanisms that might be in the toolkit. But I think they are generic and should be able to be applied elsewhere. And it's not rocket science, but I do think in that sense it might be helpful, but only as a tool. It's not the magic bullet. So if it doesn't work for you, or it doesn't work in the tool, in the setting, or if you had your bits and pieces out of it, that's perfectly fine. It's not a clinical intervention in that sense that lives are at stake if you don't use it.
Yeah, I would add to that there's nothing to be lost in using it. And although we've built this framed around ICBT, so some of the content in there has come from the specific literature around ICBT, like the determinants of practice, from the review that Christian and others have been involved in. The general principles are intended to, to support implementation activity more generally around different kinds of interventions. So, the stakeholder engagement process, for example, that's very generic, and it sounds obvious, but I still think that's often not being done very well or in a very systematic way. And in a way, we force people to keep that on their agenda all the way through. So things like that are transferable, but I'll stop and hand over to Josien.
Yeah, I was just thinking along the lines of what I said earlier. I'm really positive about the tool and completely agree with what Tracy said. That it sort of it forces you to explicitly include feedback from your stakeholders in the process in a very structured manner. So I think that's a very important lesson. I am still, because I do believe also in the results that we found, that we might have to think about what Bianca said earlier as well. Are we being disruptive enough? And in the toolkit, there are two principles that might be a bit contradictory. There's one that's be different, think outside the box. And then there's one that says be feasible. And I think that what we might have found is that people tend to put more focus on the be feasible. And this is obviously very logical and pragmatic. But it also means that perhaps if there are very difficult barriers in front of you that you don't seem to see a solution for right now, you tend to bypass them and go for something else that you think you can fix. And if then that barrier still has too much influence, I'm not sure whether that will be enough of a solution. It'll tweak things. It'll make it better than it was if you hadn't done this. I do believe that. But I do also think we need more research into how we can make it even better. How we can make sure that the implementers can actually be more facilitated even in their work.
Fantastic, thank you. And as a true researcher, we end this panel discussion saying we need more research. So thank you, all of you, for this very interesting discussion of our results. Thanks, Christian, Tracy, and Josien.